Hello, everyone. Welcome to the first official webinar in a six-part educational webinar series hosted by the American Professional Society on the Abuse of Children and the Vincent J. Fontana Center for Child Protection of the New York Foundling. During the six-part webinar educational series, some of the topics that will be discussed will be trauma-focused cognitive behavioral therapy for children in foster care. When does poor parenting cross over into psychological maltreatment? When faith hurts, recognizing and responding to the spiritual impact of child abuse. Cultural norms and cultural shifts regarding physical punishment. And lastly, interviewing the child who is recanting sexual abuse. You'll be receiving a brochure for the entire webinar shortly. I would like to also let everybody know that if you are on this webinar today, you have access to, if you would like to become a member of APSAC, the American Professional Society on the Abuse of Children, you just need to type in MEL20 for 20% off. I will also be sending that information to you over email once the webinar is complete. So for today's webinar, it is titled Adverse Childhood Experiences and Their Relationship to Child Well-Being, Biomedical Disease, and Premature Death. Today, our presenter is Dr. Vincent J. Felitti. Dr. Felitti is an internist and infectious disease physician, was one of the founding physicians of Kaiser Permanente in San Diego in 1968, and was the founding chairman of the Department of Preventative Medicine in 1975. He is the co-principal investigator of the 17,000 patient Adverse Childhood Experiences ACE study. Dr. Felitti is a clinical professor of medicine at the University of California and a fellow of the American College of Physicians. He is currently the senior editor of the Permanente Journal. Dr. Felitti has served on the advisory committees of the Institute of Medicine, the American Psychiatric Association, and the Committee of the Secretary of Health and Human Services for Healthy People, 2020, and many other committees. This webinar is going to be 1 hour long. There will be time for questions once that hour is complete, if you're able to stay after the time. You can type your questions in to either the Q&A or to the comment section, and we will read your questions later. So I would now like to welcome Dr. Felitti. Thank you.
Well, thank you for inviting me, and I'm glad that so many of you are here. The ACE study, the Adverse Childhood Experiences study, is about how we get from the left-hand picture to the right-hand picture. How do we go from a newborn with its extraordinary potential to the man lying on the street whom we overlook? And the answer to this difficult question relates directly and in unexpected ways to difficult problems in medical practice, social malfunction, incarceration, addiction, and public health that we've been facing for a long time. The ACE study is about what we've learned exploring the origins of these problems and how we came to see that what we view as the public health problem is oftentimes someone's unconscious solution to problems about which we keep ourselves unaware. The implications of this for prevention and treatment are major, and so too has been the resistance to using this information clinically, although that is slowly beginning to change. Let me summarize what we learned in the ACE study to give you some structure right at the beginning. We found that adverse childhood experiences are very common and quite disturbing, and hence are mostly unrecognized. They turn out to be powerful predictors of adult social malfunction, emotional anguish, health risks, biomedical disease, and premature death. And that combination makes ACEs the leading determinant of the health and social well-being and economy of the nation. They have a great deal to do with the lives of all of us, and now are attracting increasing legislative and judicial interest around the United States. The study began with this woman in the mid-1980s who taught us that, as is the case with smoke and fire, the smoke that is the most obvious symptom of a house fire is not the essence of the problem. She came to our obesity program in 1985 asking for help with her problem. Our first mistake was in accepting her diagnosis of what the problem was. We massively reduced her weight non-surgically in 51 weeks from 408 to 132 pounds. And her type 2 diabetes disappeared. But we also exposed the real problem, although the impressive results led us to think that we knew what we were doing. One might wonder, for instance, why her weight gain began at age 11. Why not 4? Why not 33? Oh, and by the way, in terms of adult onset diabetes, we found in a series of 320 obese type 2 diabetics that 71% of them were no longer diabetic at the end of obesity program completion. Most people, of course, would think that that's a useless observation because such major weight loss is so unlikely. But that's merely because obesity is not the core problem to be treated. One has to uncover and treat the causal issues underlying the obesity. Here's the weight curve of this woman. Looks kind of like an Olympic ski jump. 408 to 132, she stays there a couple of weeks, and then in one 3-week period, regains 37 pounds, which I had not conceived as being physiologically possible before that. And in short order, she's back over 408 in a faster period of time than the weight was lost. And exploring this, why? Why this weight regain? Why did your weight begin at age 11? We discovered, she told us, that at work, a much older man had propositioned her saying, "You look pretty good. You lost all that weight, Patty. How about you and me making it every week?" And that was the day the sleep eating began. In pursuing why this extreme response, we discovered that at age 11, her grandfather began having vaginal intercourse with her over the next 10 years. And suddenly, even her job made sense. She was a nurse's aide on the night shift in a convalescent hospital. Her job was to keep the old people safely in bed. We ran into another incest case about a week or 10 days later, and that prompted me to start asking questions routinely about childhood sexual abuse. And ultimately, the ACE study came out of this because we discovered that child sexual abuse was so vastly more common than we had ever anticipated. And we stumbled into so many other problems during the developmental years of children that the question arose, does this exist in a general population? Or is this just some aberrant finding in a group of people that I had managed to accumulate somehow? The CDC became interested in this, and we cooperated with designing the study. The design of the study was, as is outlined here, we had an unusual department of preventive medicine where 58,000 people a year, adults, were coming through for comprehensive medical evaluation. We decided to ask 26,000 of them if they would help us understand more how childhood experiences might affect adult health. 17,337 agreed to help us. So this was our starting point. We matched current health status here, average age 57, almost exactly half men, half women, 80% white, including Hispanic, 10% Black, 10% Asian, 74% had graduated from college, a clearly middle-class population. And we matched current health status here against what had happened to them back in childhood in the first 18 years of their life. And we did this in 2 waves so that we could make any necessary midpoint corrections. And then we followed them for the next 20 years, matching what had happened back here against adult pharmacy costs, ER visits, doctor office visits, hospitalization, and death a half century or so later. This was really an extraordinary undertaking. The 10 categories that we studied were selected merely because they were the 10 most common in the obesity program where all of this began. So there were 3 categories of abuse: major psychological abuse, basically recurrent humiliation, 11% acknowledged; major physical abuse, I don't mean spanking, I'm talking about serious, big-time beating with fists, sticks, and other objects, 28%. Contact sexual abuse, oral, anal, vaginal, etc., 28% for women, 16% for men, 22% average for the group. Major emotional neglect, 15%. I'm sorry. Major physical neglect, 10%. Household dysfunction, growing up in a home where one of the members of your household was an alcoholic or a drug user, 27%. Losing a biological parent before the age of 18 for any reason, abandonment, death, suicide, disease, what have you, divorce, obviously, 23%. Growing up in a home where one of the members of the household was chronically depressed, mentally ill, or in the state hospital, 17%. In a home where mother was treated violently, 13%. In a home where one of the members was imprisoned during the first 18 years of your life, 5%. So those were the 10 categories that made up the ACE study. They are not the only 10 in the world. They were simply the most common 10 in our clearly middle-class adult population of 17,500 people. Now, no one is ever going to get this information without routinely asking questions that we've all been taught as children that nice people don't ask. And importantly, this is best done initially, not face-to-face, but rather by a well-devised, comprehensive questionnaire filled out at home, and then further expanded in the exam room. We created an ACE score since we were dealing with monumental amounts of information. The ACE score is the count of the number of categories of those 10 adverse experiences, not instances or events, but categories. So an ACE score of 0 was acknowledged by 1/3 of the people. An ACE score of 5 or more by 11%, by 1 in 9 people. So 67% of this middle-class adult population experienced at least one category. And if any one category was present, there was an 87% chance that at least one other category would be present, and a 50% chance that 3 or more categories would be present. And we found that women were 50% more likely than men to have an ACE score of 5 or higher. So in other words, every doctor in the country is going to see at least 2 ACE score 5 or higher patients every day. They will not be recognized. But what does this look like in the office? So let's take a look at this video clip. This is an interesting man, a quite insightful guy, an amateur psychopharmacologist in a way, also a semi-pro saloon fighter. He might have been a cowboy in another era, or maybe working on an oil rig or some other isolated job far from home today. The backstory is this. His parents divorced when he was 3. He never saw his father again. His mother remarried when he was 5. For some reason, his stepfather saw fit to beat him pretty much every day. He told me he remembered vividly one day at 8, he's walking to school, and the thought crosses his mind, nobody is ever going to be there for me in my life. When he's 20, he comes home one day, finds his stepfather beating his mother, impressively takes a heavy cast iron frying pan, fractures his skull, and produces 5 long bone fractures. He's imprisoned in Rhode Island for attempted murder, ultimately gets out, becomes a good citizen, very reliably sends his quite significant paychecks home to his 3rd wife. But he works away from home most of the year, as though the memory of home is still untrustworthy. So listen to his clarity of statement about the use of 3 substances, his addictions, to keep the door closed to the past. He has something very important to say about addiction. That is to say, the unconscious compulsive use of psychoactive agents. Listen to what he says about the functional benefits of what we mislabel dysfunctional behavior. It's a very important point that he makes. Whoops.
20 to 25 years drowning out some poor childhood experiences with drugs, alcohol, cigarettes. Got rid of the drugs, got rid of the alcohol. Next thing I'm going to get rid of is the cigarettes. And I had no idea that the nicotine played such an important part in keeping that door closed.
And keeping the door closed to
The memories that I've blocked out with all these years with the alcohol and the drugs.
so you see what's happening to you now as related to what happened to you at the incident.
Yep. I found a way to block the emotions and the memories.
Yep.
Drugs, alcohol, cigarettes.
So he's making a very important point, because he's saying that what we see in public health as the problem is for him an important short-term solution to problems we know nothing about. The importance of that is that we commonly are not treating the core problem, but simply the most obvious manifestation of it. And our treatment attempts to take people's self-treatment away without understanding anything about what we're doing. So addiction is the unconscious compulsive use of psychoactive agents or materials. Or as we had painted on the wall of our obesity program building, it's hard to get enough of something that almost works. You know, maybe the next cigarette will do it, or the next drink, or the next whatever I'm eating, or the next dose of whatever I'm buying on the street. So the traditional concept is that addiction is due to characteristics that are intrinsic in the molecular structure of some substance. And what we found in the ACE study was that addiction highly correlates with that individual's childhood experiences. Let's look at smoking first. Here we're matching pack a day or more smoking with ACE score as a child. And what you see is a very clear dose-response effect. He spoke forcefully about the antidepressant, anti-anxiety, and anger suppressant effects of nicotine. They occur within 15 or 20 seconds of inhalation. The risks are major, but they're 15 or 20 years away. Maybe that has something to do with our problem treating many of the addictions. We're treating the manifest symptom rather than the basic cause. Here we'll look at self-acknowledged adult alcoholism. Again, a very clear dose-response relationship to underlying ACE score. Here we look at self-acknowledged IV drug use. Now, this was interesting because at ACE score 6, the relationship to underlying ACE score was so huge, it was a 4,600% greater increase than an ACE score 0 individual, that it really doesn't fit on this graph without distorting the rest of the graph into oblivion. And I remember epidemiologists at the CDC telling me that those were numbers, 4,600% increase, etc., that they likely see once in a career. Now, you think you read in the newspaper something increases prostate or breast cancer by 30% and everybody goes nuts. Here we're talking about thousands of percent increases. Something to keep in mind here, everybody knows about crystal meth, the dangers of crystal meth, people die from it, etc. Virtually no one knows that in the United States, the first really successful prescription antidepressant introduced for sale in 1940 was methamphetamine. Does that mean anything? Here's a full-page ad from the Journal of the American Medical Association in 1943 for methamphetamine, highly successful antidepressant. But isn't it dangerous? Well, if you don't understand dosage, pretty much any drug can become dangerous. You know, you take 30 aspirins instead of 2, you've taken a suicidal dose. Double your digitalis, get a better effect from it. You'll probably die within about 2 weeks. So let's look at the functional aspects of what we commonly dismiss as dysfunctional behavior. This man became obese as a child after his parents divorced, and he had to live with his violent alcoholic grandfather so his mother could work. And he vividly recalls eating for solace, as in our phrase, comfort food. And as he grew obese, he discovered that obesity offered some advantages. When you listen to him, keep in mind our phrase, throwing your weight around. So let's listen.
It wasn't that I ate because I was hungry. And it was, when I look at it, it was just a place for me to feel safe. As a child, I remember there was a point, I would probably say, all the way from kindergarten to, God, I don't know what grade, but I used to get beat up all the time. All the time. And when I got the weight on, didn't happen.
So he's talking about the unspoken benefits of obesity, as in our expression, throwing your weight. It's easier to blame McDonald's for why kids get fat, but McDonald's is merely an intermediary technique that's used by some people, not a basic cause. Actually, you'll find that the relationship of childhood onset obesity to divorce is quite impressive once you routinely inquire of the age at which weight gain began. So the question of onset of age is actually the single most important question in understanding obesity for treatment. Here's a woman you might have known when she was a little girl, who was being molested by multiple people, but that was never recognized by her parents or anyone else. She ate to reduce her anxiety and then realized that obesity reduced sexual attention. And the key point, again, is that what we see in public health as the problem may be viewed by the patient as a solution, which has a lot to do with why certain problems are so difficult to treat, because we're not treating the problem, we're trying to take away someone's solution. Listen to what she has to say.
Ella H. started the interview by spontaneously commenting on the threat she felt when her psychiatrist recommended bariatric surgery to treat her obesity, and offered to sign the necessary paperwork to have Kaiser Health Plan pay for the procedure.
Can I get comfortable first? And then he says, no. He says, when drug addicts come, we take them off the drugs first. And he would take me off of my drug. Food was my comfort food. I coped with life with food. And it's really strange tonight. I guess the Prozac's helping, because when I'm taking the Prozac, I will lose a little bit of weight. And I just feel that he was taking away my safety. And so I decided not to even bring the paper to the doctor and have it done, because I'm not ready, I don't think, to get the weight off and know that I can't gain it back and can't be safe again.
Here's a woman who was extensively molested as a child, and she coped with that by 3-pack-a-day smoking. because of the psychoactive benefits of nicotine and controlling anxiety, etc. As a result, she developed subclinical emphysema, but she also remained slender at 135 pounds. She gets married. At age 35, her husband convinces her to stop smoking. All of a sudden, sexual notice that she had no experience dealing with is a big problem. She eats to control her anxiety and goes from 135 pounds to 310, at which point she converts into overt respiratory failure and has to be on oxygen 24 hours a day. Some years later, we took her into the weight program and took her from 310 down to 150 pounds. And that cleared her need for oxygen supplementation. We were, again, naively proud of ourselves, thinking what good we had done. But incredibly, she chose to regain the weight and go back to 24-hour-a-day oxygen to avert problem with sexual attention that she couldn't handle.
You supplied me recently a lengthy autobiography, a number of dozens of pages altogether. And on the very next to the last line, you said something that I thought was extraordinary. Let me read it to you because I think it's remarkable. I believe smoking 3 packs a day and weighing 300 pounds are not the problem. They're the symptom. Took us a long time to figure that out here. You just actually dropped that. There's no, of course, anyone knows that. So you are in respiratory failure on 24-hour-a-day oxygen.
Yes.
Major amounts of weight, overweight.
Yes.
And you demonstrated, or we demonstrated together, a couple of years ago that when you had a major weight loss in the APSAC program here, that your need for oxygen disappeared.
That's correct.
So if you lost 100 pounds approximately, the need for oxygen would no longer be there. The weight back. Most people have very little understanding of why people get fat or regain. I mean, they're stuck with the simple belief, don't you know it's bad for you, etc. And people tend to know even less about smoking.
Yes.
It's labeled an addiction as though that somehow explains it all.
Right.
That way. And you make this extraordinary statement about what we perceive as the problem really being the solution. Can you explain more about that?
Yes. I think I've come to that conclusion. It hasn't been quite immediate. It's come to me over the last few years of analyzing just exactly where I've been and what I've done. Obviously, I was a 3-pack-a-day smoker when I was thin. I didn't have a weight problem until after I was 35. But I've done several OptiFast type things, and I finally came to the realization on my own that the reason I put the weight back on was to protect myself.
Minutes later, she begins speaking of her chronic depression. Most people speak of depression as a disease. Many say it's genetic. Some say it's due to a chemical imbalance in the brain. There's something to be said for each of those. But What if depression were not a disease? What if depression were a normal response to abnormal life experiences? Let's look at that. When we match self-acknowledged chronic depression to underlying ACE score, again, you see the very same dose-response curve. As the ACE score goes up, the probability of depression a half century or so later goes up in this very clearly dose-response effect. If you look at suicide attempts, self-acknowledged suicide attempts, very strong response. Once again, we cannot put in ACE score 6 without compressing the rest of the slide to illegibility, because at ACE score 6 or higher, the likelihood of attempted suicide runs from 3,100 to 5,000% greater than at ACE score 0. And for those of you with a mathematical bent, you might note the exponential progression indicating an internally self-worsening process. We looked at hallucinations. To get this, you have to ask everybody. Obviously, we don't ordinarily do that, but when you do, look at what you see. That as the ACE score goes up, at ACE score 7, you have a 10% acknowledged prevalence of hallucinatory activity. And because we felt that some people would say, yeah, but the reason that is because at an ACE score that high, people are going to be using street drugs and alcohol to control their feelings. That's what's giving them hallucinations. So in the pale lines, we have patients who did not use alcohol, drugs. You see essentially the same relationship. We looked at high-level promiscuity that we defined as 50 or more sexual partners. You see a very clear relationship to ACE score once again. And ultimately, we realized that this slide, this information might better be termed looking for love. Maybe the next woman or man is the one who's going to love me. And sometimes when relating to one's peers is too threatening, that hope will be filled by a child or by photographs or by a farm animal. We looked at the relationship of ACE score to unintended pregnancy or elective abortion. Again, you see same relationship. So up to now, we've been looking at the long-term effects of various coping devices that are in play because of their short-term benefits, like alcohol, overeating, smoking, street drugs. More complex is the issue of what happens as a result of the complex hyperstimulation of certain areas of the brain as a result of what's termed toxic stress, chronic unrelieved stress. There's a third category that we won't touch on, epigenetic effects. It's a very important issue, but when we put the ACE study together, the word epigenetics barely existed. The field has grown explosively, and you'll be hearing more of that in coming years, I have no doubt. So we look at how ACEs increase the likelihood of heart disease, and you see each of the 10 categories of adverse childhood experiences has its own relationship to an increased likelihood of heart disease after we have corrected for age, race, education, and conventional Framingham study risk factors like smoking and diabetes. Other biomedical diseases, cancer. This woman is articulate, well-dressed, holds a significant position in a large university. She's obviously doing well and is just the sort of person from whom we perhaps choose not to seek an abusive childhood history. I mean, no need to bother her with this. Of course, we'd skip that history for our own comfort. We'd be smart enough to say that we saw no need to risk upsetting a patient who is doing so well. So listen to what she has to say. I once would have totally dismissed her idea that childhood experiences were related to subsequent cancers. But organ transplantation has provided us the links. We'll come back to that in a moment.
Can you tell just by looking at me that I was an abused child? Can you tell that I was sexually abused routinely, that I was neglected, starved, beaten? Probably not. You would have to ask in order to find out, and that's not the sort of thing that people typically ask about. The downside of having this kind of childhood is that it translates into health problems in adulthood, at least in my situation it seems to have done. I'm now recovering from my third battle with cancer. Not the same cancer, 3 different kinds of cancer. I've had chronic pelvic pain, migraines, the whole laundry list of medical complaints, all of those sorts of things that are very difficult for physicians to figure out. Growing up that way instills a constant fear, a constant state of turmoil that's just under the surface of a veneer that's fairly thin. Little things become scary in an atmosphere like that. And once you've internalized all of that, it's very difficult to let go of it.
So she obviously believes that what happened to her as a little girl in terms of the incest history is the cause of her 3 cancers. How does that work if that's true? Actually, we've had the information explaining that for some time without putting it together. Everyone knows that if you get an organ transplant, you need to be on lifetime immunosuppression so you don't reject the organ. Some people will correctly have heard that one of the long-term side effects of lifetime immunosuppression is an increased risk of cancer. How does that work? Well, all of us every day are forming small number of cancer cells from a wide variety of organs. Our immune systems recognize them, destroy them, and we never know that that's going on. So if anything suppresses our immune systems, like immunosuppressant drugs that she's talking about, that can increase the risk of cancer because those cells that are being produced every day are no longer being destroyed. Well, one of the effects of toxic stress that I mentioned before, hyperstimulating certain areas of the brain, is to produce immune system suppression. Another effect is to cause the release of pro-inflammatory chemicals. Now, in our previous slides, we were looking at the relationship of A-score to heart disease when the conventional Framingham risk factors were not present. Hyperstimulation of other areas of the brain causes the release of these pro-inflammatory chemicals. They inflame the lining of arterial blood vessels, and that effect produces a magnetic attraction for cholesterol as it flows by, pulling cholesterol out of the blood and forming cholesterol plaques that obstruct the vessels, hence causing coronary artery disease. Let's look at the next case now. This is a woman, rather remarkable lady, United States federal judge, the incest victim of her father for about a decade as she was growing up. Worse yet, he used to bring her into saloons at night and sell her to strangers for sex. She describes all of this in great detail in her autobiography, really an extraordinary autobiography. She wrote it basically because she wanted to help people understand what was going on in their lives. She, rather than committing suicide or becoming a mass murderer, graduated from high school, got a scholarship to college, graduated, got a scholarship to law school, graduated, ultimately became a United States federal judge. I mean, that's a really big deal. It would be very easy to say, isn't it wonderful how this poor little girl with that hideous history has been so resilient? And that shows the weakness in our conceptualization of resilience, which is typically related to income, occupational success, academic success, etc. No one looks at biomedical outcomes. One of the major researchers in this area, a woman named Emmy Werner, on page 67 of her excellent book, talks about the relationship of resilience to, or lack of resilience to, biomedical disease. Judge Bullock has had 5 different kinds of cancer. In addition, she has 3 different autoimmune diseases: lupus, multiple sclerosis, and rheumatoid arthritis. We studied 21 different autoimmune diseases in the ACE study and found a clear dose-response relationship of ACE score to 16 of those 21 autoimmune diseases. So this is really quite extraordinary to see, and it's important to keep in mind when we think somebody is really doing well, if we don't look at biomedical outcomes at the same time. So, in conclusion, we saw that adverse childhood experiences determine the likelihood of the 10 most common causes of death in the United States. And the top 10 risk factors are smoking, severe obesity, physical inactivity, depression, suicide attempts, alcoholism, illicit drug use, injection drug use, promiscuity, and history of sexually transmitted diseases. With an ACE score of 4 or more, the majority of adults have multiple risk factors for these diseases or have the diseases themselves. And this is the making of big medicine: coronary bypass surgery, lung or liver transplants, bariatric surgery. It's so easy to become intrigued by the technical wonders of these procedures that we never discomfort ourselves by asking why problem occurred. Many chronic diseases of adults are determined decades earlier in childhood, not by childhood disease as once was the case, but by life experiences. The risk factors underlying these adult diseases often are effective short-term coping devices. This is an important insight into the origins of alcoholism, street drug use, smoking, obesity, promiscuity, violence. It's hard to give up effective short-term coping devices, especially at the request of somebody who has no idea what's gone on. So there's a public health paradox that you should keep in mind, that many of our most common and intractable public health problems are unconsciously attempted solutions to personal problems dating back to childhood that are lost in time and then further concealed by shame and by secrecy and by social taboo, because we've all been effectively taught as children that nice people don't talk about certain things in life. God, surely don't ask questions about them. The Framingham study was of great importance in showing us the predictive risk factors for many diseases. Obesity for diabetes, smoking for lung cancer, cholesterol for heart disease. And what we've been looking at in the past hour have been the determinants underlying those risk factors and seeing that most of those determinants take place in childhood. We have a publication from the prospective arm of the study showing that people with an ACE score of 6 or higher have a life shortening of 19.7 years, basically 20 years shorter than it is at ACE score 0. But why are these problems so intractable? These are PET scans of the brains of 2 3-year-old boys that help explain this and provide an insight of major importance, showing the translation of life experience into neuro. PET scan is a very sophisticated kind of X-ray showing biochemical activity here in the brain. Left hand is a 3-year-old normal American boy. Right hand is a 3-year-old child taken from a Romanian orphanage. You may remember about 15 or 20 years ago when it was discovered how terribly children were treated in the Romanian orphanages with massive degrees of neglect. They were fed and given water to drink, and that was basically it. And what you see is on the right, many areas that are densely colored on the left, indicating normal biochemical activity, are black. And at age 3, when brain is still being formed, I don't think it's going to tax anyone's imagination to think that maybe this lack of biochemical activity is going to affect the kind of brain that's being formed. Namely, we're looking at the translation of life experience into neuroanatomy. Maybe that has a lot to do with why these things are so difficult to treat later in life. So we can summarize the findings of the ACE study this way. We have this major base of adverse childhood experiences, typically unrecognized, which produce disruptions in brain development we now understand. And those disruptions produce various impairments, maybe in social activity, an emotional state, or an ability to learn. And by the time these people become teenagers, they have enough freedom to try to find something that helps them feel better. Eating and alcohol and buying antidepressants on the street like crystal meth all help short term, but long term, they produce significant problems, disease, disability, social problems. A number of people die early. So this has really been a rather impressive discovery. How do we use the information? How do we go from where we are today to where we could be? Well, I would strongly suggest that 2 things are requisite. One is an awareness that these problems exist. That is to say, the underlying causal issues exist rather than dealing with the readily evident manifestation of those, the symptoms, so that we don't treat the smoke instead of dealing with the house fire. And secondly, is recognizing these cases as they come up in medical practice. Here's where the study was carried out in my department of preventive medicine, we carried out 1.2 million comprehensive adult patient evaluations since 1975. Step one of that two-visit process was to fill out a lengthy medical history questionnaire at home. This was 10 pages long. And as a result of the findings in the ACE study, we took the questionnaire we had been using, which was really a terrific biomedical questionnaire, and integrated the ACE questions. My colleagues assured me I was crazy, patients would be furious, no one would answer those questions honestly anyway, etc., none of which was true. We also discovered that there were a lot of other potential ACE questions. We're not amongst the 10 most common in our clearly middle-class population, such as, have you ever lived in a war zone, ever been a combat soldier? Who in your family has committed suicide? Who in your family has been murdered, has had a nervous breakdown? Were you ever molested as a child, held prisoner, tortured, raped, etc.? So we integrated these questions into the questionnaire, and then at visit one, we would collect the questionnaire, put it into a digital scanner, and this would pick up all of the yes answers and organize them by category. So here's a real output from a middle-aged woman. Amongst the things we see here, she acknowledges being physically abused as a child, verbally abused, sexually molested, etc. She has problems falling asleep, staying asleep, awakens tired, down in the dumps, problems controlling her anger and caring for herself, etc. Distinct weight gain in the past year, recurrent abdominal pain, etc. What do you do with this information? Well, what we found works best is in the exam room, the examiner would review the questionnaire before going in to meet this patient at visit two. Visit one, by the way, was totally occupied with collecting biomedical measurements. And say to a patient, I see on the questionnaire that. Can you tell me how that's affected you later in your life? The result of that was really quite dramatic. Our old method of biomedical evaluation led to an 11% reduction in doctor office visits in the subsequent year. We were very pleased with that. The new method, integrating the ACE questions, what one would call a biopsychosocial evaluation, in a 135,000 patient sample, 2.5 years throughput, led to a 35% reduction in outpatient visits and an 11% reduction in emergency room visits in the subsequent year compared to their prior year. The dollar impact of that is extraordinary. So extraordinary that 23 state legislatures have now passed legislation designed to support the use of the ACE study in everyday medical practice. So in summary, what we saw was that adverse childhood experiences are common, but typically unrecognized. Their link to major problems later in life is strong, proportionate, and makes sense. They are the nation's most basic public health problem. And it's comforting to mistake intermediary mechanism for basic cause. Oh, McDonald's is why kids fat. That what presents as the problem may be someone's attempted solution to problems we know nothing about. And unknowingly treating their solution may be threatening and cause them to flee treatment. And that primary prevention, keeping this from happening in the first place, is presently the only feasible population approach. Change has been resisted by us in spite of enormous benefits. So I would say that a biopsychosocial and trauma-oriented approach to medical evaluation is feasible, affordable, and acceptable to patients. It's possible to move from our current symptom-reactive mode of practice to start dealing with basic causes and also significantly improve medical care while reducing its cost, and that a trauma-inclusive, comprehensive medical history questionnaire is proposed as the routine entry mechanism into all ongoing care, whether it be medical, psychological, or institutional, such as prisons. If you want further information, here are some sources. I surely hope that this has been interesting and useful to you, and that many of you will integrate it into your daily work. The future of all of this will depend on people like you integrating it into your daily work. So I thank you for inviting me here. We have time now for questions.
Hi, yes. Dr. Felitti, can you hear me?
Yes.
Okay, I'm going to ask you a couple questions people have posed.
Sure.
The first one is, oh, and thank you so much, but the first one is, how do we deal with the issue of ACE in the criminal justice system? In other words, how should the system weigh ACE versus personal responsibility in determining punishment consequences for illegal behavior?
A lot of these very good questions, like the one you're asking, are yet to be definitively answered. So you all can be participants in figuring out what the answers are. But what I would suggest, something to keep in mind, what if you were to, in a prison or in juvenile hall, get together a bunch of inmates, say 20, 30, 50, and have them anonymously ahead of time fill out the one-page version of the ACE questionnaire that we developed. Then pool the results from these anonymous questionnaires, bring the people together in the auditorium, and project the results on the screen. What is that clunking noise I'm hearing?
I'm sorry, that is me getting all the questions for you. I will stop typing. Go ahead.
Project the questions on the screen, asking the audience, what do you think this means? The advantage of that technique, which works very well, is that people don't need to feel they're talking about themselves. I mean, hey, I'm not talking about me. We're talking about what's up on the screen there. And so the discussions often become very, very meaningful with people sharing things, et cetera. And we worked this out in the obesity program and found that it really worked extraordinarily well. So that's a good starting point to keep in mind. Another version of that would be if you could get your city newspaper or your college or university newspaper to publish the one-page version of the ACE questionnaire, asking readers to respond anonymously, collect the data, pool the data, publish it. It will have an intense effect on the community because the results are so unexpectedly different from what we all anticipated. And it's a good starting point for various discussions of various types.
Okay, thank you. So another question that was asked was, I wonder why sexual abuse is limited to penetration on ACEs. Some have been sexually abused without penetration and are equally disturbed and impacted.
Say again the last part.
So the question was, why is sexual abuse only sexual penetration on ACEs? Because some people have been sexually abused without penetration and are equally disturbed and impacted.
Oh, okay. Well, I mentioned that our question was not restricted to penetration, intravaginal penetration. We also included oral, anal, etc., and other versions of sexual abuse. So it was not limited in that way, if I gave the impression that it might have been. And certainly, issues beyond age 18, come into play meaningfully in people's lives. We simply picked the 10 most common, not the only ones in the world, in our clearly middle-class population. If things are that bad in a clearly middle-class population, they don't get better if you're in prison or living on the street.
Hi, okay. So somebody wrote, thank you so much. Somebody wrote, it'd be powerful in presenting the ACEs material if you would put it in a way that countered the unrecognized nature of the problem. That is, frame it in a way that emphasized that childhood matters and that the way we treat children, interact with children makes a difference in the adults children become. So this is more of a statement that we need to emphasize.
Well, the unaddressed issue really is, how does one best use this? My belief is that the biggest advance we could make would be to figure out how to improve parenting skills across the nation. That is to say, how could we teach 20 or 30 million young adults on the verge of parenthood how to be better parents? Not by didactic methods, not by books or by pamphlets, etc. I think it would really best be done by storytelling and depiction. So what if someone were to develop a television serial program, a soap opera, if you will, where woven into the storyline were illustrations of what supportive parenting looks like for an infant or a 3-year-old or an 8-year-old or a teenager, etc., and how it plays out later in life, contrasting that with illustrations of what destructive parenting looks like and how it plays out. Maybe some of the audience might have links to theater that would enable them to help begin to develop such a program. I think it would have enormous benefit and enormous appeal.
I agree. Thank you. Somebody else wrote, I am the mother of an adopted 6-year-old girl from the Texas foster system. She has been diagnosed with PTSD from a trauma background that includes sexual abuse. Is there any intervention to begin now to assist with preventing issues later in life?
Well, that's certainly a good and common question, and a difficult one to answer without knowing a lot more detail about the individual. One thing to keep in mind that we found repeatedly was that conventional psychotherapy, and I'm a big believer in conventional psychotherapy, is unfortunately a low efficiency process, hence time consuming, hence expensive, hence unaffordable by many people. If you can find a capable hypnotherapist, we found that hypnotherapy can be profoundly effective in short numbers of visits and hence very affordable to people. The American Society of Clinical Hypnosis has a website, and they have experienced hypnotherapists listed by city around the country, so that's worth keeping in mind. Another approach that has been beneficial is called EMDR. You can look it up on the internet to learn more about it. It has the advantage not only of being effective, but of being effective in relatively small numbers of visits.
Thank you. So another person asked, how specifically were the DOVs reduced once the biosocial approach was adopted?
Okay. So hearing that, most people would say to me, oh, that's really amazing. You sent everyone to therapy, right? No. We essentially sent no one to therapy. Well, how'd you do that? We spent some time thinking, how did we do that? And ultimately, what I realized was that by asking and using an inert mechanism initially is an important idea here, because if you're doing this face-to-face initially, most of us will not be experienced and comfortable doing that. We'll screw it up. We'll embarrass ourselves and quickly decide, the hell with this, not doing this anymore. Collecting the information by an inert mechanism, a paper questionnaire, perhaps better on the internet. We have some experience that was very satisfactory with that, is really a big step in the right direction. Then I see on the questionnaire that, can you tell me how that's affected you later in life? And listening, period. No humbug about, oh, I'm so sorry, that must have been awful, how could you tolerate that, etc. No, listening, period. And we realized that we did one other thing, and again, the patients taught us that. We implicitly accepted, because I had the experience of being stopped in the hallway by numbers of patients who had just completed their comprehensive medical evaluation and wanted to thank me for having asked those questions, and wanted to make the point that the examiner was so nice that after they heard the worst, dark history of this woman's or man's life, they were still nice to me. They want me to come back and be seen again, etc. So I realized that we had created a lay version of confession in the Catholic Church. I'm not saying that as a religious person, because I'm not, but confession is a very interesting process. It's been in use for 1,800 years, suggesting, maybe it meets some basic human need. And that brief process involves somebody telling a person who's important to them, in that case a priest, and ours a doctor or a nurse practitioner, some dark secret, typically for the first time in their life, and within a minute or so realizing they're still accepted here. So asking and listening and implicitly accepting turn out to be a very powerful form of doing. The other half of the question might be rephrased as, well, why do patients come to see doctors? And why did they, why did they reduce that by 35%? Well, the Hungarian psychoanalyst named Michael Balint made the memorable comment, patients see doctors because of anxiety. Oh, I've had these headaches for 20 years, doctor. I'm so afraid I may have a brain tumor. Doctors see patients because of disease, and therein lies the problem between the two. No, if you had a brain tumor, you'd have died 19 years ago. Is anything else bothering you today, etc.? So collecting developmental information, converting from a biomedical approach to a biopsychosocial approach, has turned out to have major benefits.
Thank you. So we'll do one more question, and then we'll wrap up the webinar. So the last question I'm going to give to you is, when prevention is not possible and we have people with an ACE score of 6 or more, what are the most evidence-based modalities to promote the best outcome?
Repeat your last sentence again, please.
Yes, of course. So I said, when prevention is not possible and we have people with ACE scores of 6 or more, what is the most evidence-based modalities to promote the best outcome?
Oh, okay. Bringing people together in small groups, 6, 10, 12, people with similar problems, having them fill out the ACE questionnaire anonymously. Again, putting up on the screen, the pooled results from the room, and opening discussion. What do you think this means? We did that in the obesity program. It was enormously productive. And I highly recommend experimenting and getting, some sense of how effective that is as a beginning. Where you go after that depends on the specifics of any given individual. For instance, for one person, any given ACE might be a great deal more damaging than the same ACE to a different person, depending on what their background experiences have been. So you need really to get further detailed information on each person to figure out what the best approach is. But in terms of a group meeting like that, the implicit realization that other people have these problems too, that other people in the room, they're kind of like me, they're nice, etc., is an important discovery. And keeping again in mind the role of hypnotherapy in terms of often being effectively able to help people with specific problems in short periods of time.
Well, thank you so much for answering the questions. I hope we were able to get to most people's questions. I want to thank you for an excellent workshop and for everything we learned today. Thank you so much, Dr. Felitti.
You're more than welcome.
Okay, everyone. We are not giving access to the PowerPoint because of confidentiality issues, but we will be having a recorded version of the webinar sent to you sometime within the next week. Thank you so much. Have a good day.